Hello, everybody. This is Chris Fox. I'm the Department of Emergency Medicine at UC Irvine, and it gives me great pleasure to lecture to the University of Santo Tomas on this super fun topic, one of my favorites, game-changing POCUS in the emergency room. So we're going to go through some fun cases and see how point-of-care ultrasound made a change in the diagnosis. All right. I love this ultrasound video because it looks like a happy face. It's actually a bowel obstruction, but it looks very happy. We see maybe some ascites here and some loops of bowel floating around and some plicae circularis down here. It's kind of fun there to see a bowel obstruction in the setting of an umbilical hernia when there's a big happy face. All right. Well, this was a case I had a long time ago, but it's so fun to talk about. This was a 22-year-old female who was complaining of an asthma attack that was witnessed by her next-door neighbor. She was bradycardic, she was hypotensive, cyanotic in the field, and by the time they got her to the emergency department, she was in pulseless electrical activity. And so, she didn't have a pulse, and there was some electrical activity on the monitor, but basically she was coding. And so the question was, why is this person coding? And, the whole thing with asthma kind of threw us off a little bit. That the neighbor thought she had asthma, and they saw her laying on the ground, like, oh, she's having an asthma attack. And so we listened to her lungs were clear, didn't really seem like asthma. And then there's a medical student standing there and said, hey, she was found outside. Maybe maybe she fell out of a tree or got hit by a car. We should do a fast exam. And I said, okay, not a bad idea. So we do a fast exam, and this is what it shows here. And the medical student was right to want to do a fast exam because there's some free fluid here in Morrison's pouch between the liver and the kidney. And indeed, that fast exam was positive. And in the setting of a coding patient, a positive fast exam, we went ahead and started to cut the rest of the clothes off this patient. But she didn't have any other bruising or contusions or signs of trauma. And okay, so now we're like, why would a 22-year-old female have a positive fast exam? She'd be coding, yet no signs of, oh wait, maybe she has an ectopic pregnancy. So we did this ultrasound in her pelvis, and we can see actual blood extravasating in her pelvis right here, just swirling around from a ruptured ectopic pregnancy. We don't even have a pregnancy test back, but we know this patient has a ruptured ectopic, well, we think she has a ruptured ectopic pregnancy because she's young, she's female, she's coding, and she's got blood swirling around in her pelvis. And so we call OBGYN, we hang blood, and she goes to the operating room, and she survives. Really crazy case, and kind of like one of my first cases, actually, that got me really excited about point-of-care ultrasound. That's why these images look a little old. Now, let's fast forward to a lot more contemporary type of case. This is a 32-year-old female brought in with altered mental status. The family called 911 because she was kind of sleepy and confused. She's hypotensive in the rig on the way to the ER, and certainly is when she gets to us. She's tachycardic hypotensive and basically unresponsive, and her GCS is 3. So we intubate her, and we do an EFAST. And as we're doing the EFAST, we see this right here. She's got fluid here in Morrison's pouch between the liver and the kidney. And so when we see that, we go, okay, we know what to do now in a young female with a positive fast exam. We start thinking about the pelvis. And indeed, we're doing a transabdominal imaging here in her pelvis. And this is a mass that's outside of her uterus. There's a fetal pole in here. And so free fluid plus a mass in the pelvis with a fetal pole, thick ring of ectopic pregnancy. The uterus is actually over here, it's empty. And so lo and behold, we have another ruptured ectopic pregnancy, and we contact our friends in OBGYN and show them these images at the bedside and hang some blood and take her to the OR, and she survives. Here's the uterus right here, totally empty. Here's that mass with the fetal pole in it. And there's like a blood clot back here in her posterior cul-de-sac. So the uterus is here, and then posterior to the uterus is this blood clot. And there's some free fluid over here in the anterior cul-de-sac. So certainly ruptured ectopic pregnancy. All right, next case. You're working out in triage. We have these triage shifts now to work out there. This is a 38-year-old female, right lower quadrant abdominal pain, weakness for 1 day, and she's got history of diabetes, past surgical history, none. She's on metformin, and her blood pressure is a little soft, 130, but boy, she tachycardic. And so we order a urine pregnancy test. It's positive. The patient did not know that she was pregnant. And so here we go, right lower quadrant pain in a 38-year-old female who's tachycardic and hypotensive. Immediately we do a fast exam, and it's positive right here. Anechoic fluid wedging out between the liver and the kidney. And immediately we know free fluid plus positive pregnancy test and abdominal pain. We want to see what that pelvis shows. And here's transabdominal of the pelvis. Here's her empty uterus over here. There's some free fluid behind that uterus. And just to the right of the uterus is this thick ring of ectopic pregnancy with a fetal pole in there. And immediately we know who to call. And we hang some blood. She goes to the OR, and she does well. And so those are 3 ectopic pregnancies right in a row there for you. I promise there's no more ectopics in this lecture. This is not a lecture about ectopics, but boy, is this something that we use quite often to differentiate these patients in the ED. We get about 1 ectopic a week, pretty common in our emergency department. So basically, we like leveraging that fast exam to raise concern. We start with that, and certainly an endovaginal approach is often required. I'll tell you, we get a lot of information transabdominally quickly without needing to use the endovaginal transducer. And then one thing to keep in mind is that just because the fetus is large and moving around and you can see it looks like a baby and everything, does not necessarily mean it's intrauterine. This one here is a 14-week live ectopic pregnancy, and it is outside the uterus. And so you really want to make sure you get your landmarks correct and make sure you find the uterus. And don't just assume it's in the uterus, but you want to find the uterus. Oh, the uterus is over here. It's adjacent to where this fetus is. So that's why it's good to be good at ultrasound. All right, moving on now. No more ectopics, I promise. 52-year-old male comes in, hypertension, coronary artery disease, AFib. He's on Coumadin. He's got fever, hypotension, and his blood pressure's soft. He's tachycardic. He's febrile. He's hypoxic. So fever, hypotension, hypoxia. He's on Coumadin, AFib, and he actually says, hey, I'm a vasculopath. He knows this word, vasculopath. He's excited to tell us that. So we know that he's going to be a tough stick. So the nurse puts in the ultrasound-guided IV right out there in triage before we get him back to a bed. Now we have established IV access, which is really important, especially in a vasculopath. So you can see the IV go in there. We trained all our nurses how to do ultrasound-guided IVs. Now we get the labs are cooking. We get a chest X-ray. A radiologist reads it as bilateral patchy infiltrates versus congestive heart failure, and basically a garbage read. We can't really. It's not helping us here, right? I mean, clinically, it sounded like it could go either way. History of CHF, but the patient's febrile. Is this pneumonia or not? So a medical student does an ultrasound of the heart and lungs, and here's the heart. And this patient, as expected, has a low ejection fraction. This is the left ventricle. This is the left atrium. And then sort of out of view is the aortic outflow tract. But we can see this mitral valve is definitely not coming anywhere near the septum, which we expect it to. And the end diastolic volume versus end systolic volume is pretty similar to one another. So this is a low ejection fraction consistent with congestive heart failure. But then the student does an ultrasound of the chest and sees this consolidated pneumonia with air bronchograms in there, and a bit of a shred sign here. So we see this, what basically looks like liver in the chest with a shred sign. That is what pneumonia looks like, bacterial pneumonia, lobar pneumonia. And then we look at the other side, and there's also pneumonia. This patient actually has bilateral pneumonia. Right away we know this patient's probably septic. So of course the lactate comes back, it's 5.8, elevated white count, and now the patient's being seen by emergency medicine resident and attending who are looking to basically resuscitate this patient, but being very judicious with the use of fluids. We saw that poor EF on that patient. So we're looking at the velocity time integral. It's kind of an advanced move there where you take the pulse wave Doppler and you put it over that aortic outflow tract, and then you basically see as the patient's breathing in and out that the VTI is very low. It's in the teens, and it's got these huge swings with respiration. So that combined with the fact that the patient has a lot of IVC collapsibility, even after getting 1.5 liters of fluids, we know we are under resuscitating this patient, and we have to give even more fluids, of course, which is a little scary in the setting of that poorly contracting LV. But after we give more fluids, the MAP is still less than 75. So we got to put a central line in this patient, because now we're giving antibiotics, we're giving fluids, we're thinking about giving pressors here in a minute. So we need some central access. We know this patient is a vasculopath. We're being careful here. We also know they're on Coumadin and elevated INR. So we're doing an ultrasound guided IV. This is the internal jugular vein here. This is the carotid artery down here. You see how close they are. Here's your thyroid. So we're just getting that line in very carefully. And then we're going to confirm its placement by seeing the catheter inside that vein. And then also we're going to look at the heart, and the right side of the heart has a little blush in it when we give a push of, as we give our IV fluids going in there. Maybe there's a bubble or two in the tubing, which is normal. You could agitate some saline if you wanted to. You don't have to. Just even 1 or 2 bubbles will cause all of this blush there seen in that right atrium, right ventricle. So we know that we are on the venous side when we place that central line. That confirms we're in the right location. And then we go ahead and start our using that central line without the need for a chest x-ray. Now, 5 hours later, the patient goes up to the ICU. They've gotten 3 liters of IV fluid. The intensivist repeats that velocity time integral. Much better now, no longer in the teens, but way up in 30, and only a 9% respiratory variation. So they turn the fluids down to maintenance and start some dobutamine. They turn off the norepi, they start some dobutamine. After 2 days, the lactate trends down, and they turn off the BiPAP, and the patient gets transferred out of the ICU. So has a great outcome, and it all started out in the ER a few days earlier with doing an ultrasound guided peripheral line by a nurse, and then a medical student did a ultrasound of the heart and lungs to make the diagnosis of pneumonia. And we did some ultrasound guided procedures there, and also did some fluid resuscitation with the velocity time integral using ultrasound. So this is a great case in this young 52-year-old male with lots of comorbidities. Here's another person. This 31-year-old female, cough and syncope, persistent fever, 6 days. She's been taking Tylenol and Motrin around the clock, Dayquil, NyQuil. She feels terrible. She went to her primary care doctor. She gets azithromycin. Started that yesterday. No other past medical history. She's a little tacky. Her blood pressure is pretty soft at 86. She's febrile. Pulse ox is 96%. She's got scattered bronchi, little pitting edema bilaterally, and her influenza test comes back positive for influenza B. And so, we get this chest x-ray, the radiologist says consistent with the viral pattern. Okay. And so we're just wondering kind of what to do next on this patient. Remember, her blood pressure is a little bit soft, 86/50. So cough, syncope, what are we going to do? Are we going to do CT angio? Are we going to rule out PE on this patient? I don't know. Let's take a look at the heart first. And still even with the fresh set of vitals here, still tachycardic, a little bit soft on the blood pressure. So we do a point of care ultrasound on this young patient. Now remember, she is like 31 years old, and she's got just poor contractility here. You can see there's just not a lot of contractility going on, not a lot of squeeze. And so that kind of tells us that this is a viral myocarditis. Normally this person, no past medical history, you would expect to see a much better squeeze there, much better ejection fraction. We can do EPSS measurements, and we see that her EPSS is 20, which corresponds to a low ejection fraction, because EPSS, or E-point septal separation, that is the distance that the mitral valve comes to the septum. We use M mode to measure that. Here's that distance on the M mode. E-point septal separation, 20 millimeters, corresponding to these to this over here on the side of the screen. So we know, 20 millimeters, that's more than 7. Should be less than 7 in normal individuals. So we plug it in our handy dandy formula, 2.5 times the EPSS in millimeters, minus 75.5, and that's where we get an EF of only 25% in a 31-year-old female. So we know this person's got viral myocarditis. We start her on some steroids. We also look at her IVC here, and we can see her IVC is pretty plump. It's got no respiratory collapsibility, and so we know that fluids-wise, we're pretty well resuscitated on this patient. So she got admitted. She got some diuresis, actually, for that low EF, the pitting edema, and the very full IVC. And, she got some steroids for the myocarditis. She actually went home About a week later, with a good ejection fraction, that's her new ejection fraction on the left, her heart responded well and she did better. Here is a new patient, a 57-year-old female comes in, shortness of breath for a month. I remember this lady, she was in bed 5. She was a university professor, sort of like an international expert on her field, and she's always flying around. She had mild shortness of breath for a month. Shortness of breath for a month, okay? Worse the last 2 days, no chest pain, mild right leg swelling, sort of comes and goes, not a smoker. Yeah, her vitals look pretty good. Blood pressure's 110, respiratory rate's a little bit higher than I'd like, 22. Pulse ox is 94, everything's kind of borderline. Her D-dimer, my resident orders a D-dimer. I hate this test. They order a D-dimer and it's negative. It's 365, less than 500. Again, a little trace pitting edema with that right leg. D-dimer's negative. What do you want to do? You're thinking to yourself, okay, she's flying all over the place. She's at risk for a PE, but she's had the respiratory distress for a month. Short of breath for a month. D-dimer's negative. Trace pitting edema on one leg. What do you do? Well, I started to think more about this being a clot because since it's been there for a month, I know that the D-dimer can go up and then it can come back down again in the setting of a clot if you wait long enough. Usually patients present more acutely, so usually you don't see them a month out, but just remember, a month out, a D-dimer is not going to be helpful to you. Get a chest x-ray, it's not helpful ever. And then we're looking at the leg here, that right leg. We can see that there actually is a non-compressible clot here, non-occlusive as well. So here's this common femoral vein right here, and we're compressing it, and we see an echogenic structure in there that prevents the coaptation or the collapsibility of that common femoral vein. So, but it's also non-occlusive, so the blood's able to get by here, and you know what? That's consistent with the blood clot that's been kind of hanging around for a month. So it's in some stage of being chewed up by the, being degraded. However, with the shortness of breath, I start worrying about this patient on having a blood clot to the lung. And so we go ahead and get this ultrasound of her heart. We do a point-of-care ultrasound. We put the probe in the apical 4-chamber view, and I'm expecting to see the left ventricle over here be larger than the right ventricle, but instead, in the setting of a pulmonary embolism, her right ventricle is actually pretty dilated, and it's been that way now for a month, and so it's had time to kind of dilate out like that. I can see her moderator band is here. That confirms to me that this is indeed the right ventricle, not the left ventricle. And it's a little bit concerning that the left ventricle is really empty, and so you don't ever want to see an ejection fraction of 100%. So this patient is definitely needing some fluids and needing some anticoagulation. And we go ahead and get a peristernal short axis. Again, we see what looks like a D sign. Looks like a D. If I freeze it here, where the D goes like that. This is the D, and then the round part of the D is over here. And this is all the right ventricle here. This is what's left of the left ventricle. It's being smushed by the right ventricle, which has such high pressures due to the fact that there's this blood clot. And so, normally the pulmonary embolism, normally the right ventricle is smaller than the left, but when the right ventricle gets as large or bigger than the left ventricle, we see a RV strain. There's another way to measure the right ventricle excursion, which we call TAPSE, tricuspid annular plane systolic excursion. And it's my buddy Ben Smith. He makes these awesome diagrams. And so you take some M mode and you just drop it there on the right side of the heart. And normally the right side of the heart is like a corkscrew, goes up and down. And so when you have a problem with the right ventricle, if it's beating against a big clot and you're worried about this patient and you want to admit them to the hospital and anticoagulate them, as opposed to a small subsegmental PE that doesn't really cause as much problems, you can think about TAPSE. So in a normal individual, TAPSE should be greater than 20 millimeters. When you measure this with M mode, it's going up and down a lot, and you can see the M mode is going up and down. All of us right now, our TAPSE should be greater than 20 millimeters. But if you have somebody with the RV dysfunction in the setting of a large pulmonary embolism, then the TAPSE is less than 16 millimeters. Greater than 20 normal, less than 16 abnormal. So just looking at this, I can tell you it's normal. Like seeing this so many times. Like I can see that tricuspid annular plane of systolic excursion going up and down. This is where the tricuspid valve hits the free wall of the RV. We're going to place our M mode right there, and then we're going to have a nice tracing, and you can see the millimeters here. definitely more than 20. But on this unfortunate person here, the TAPSE is just barely moving up and down there. And so to me, that's probably going to be less than 16 if I measure with M mode. And this is somebody that I'd worry about. And sure enough, it was 7.8 on that patient. And so you get this little waveform. You measure just the amplitude there, 7.8. That is severe RV dysfunction. What else can cause RV dysfunction besides pulmonary thromboemboli? LV dysfunction can cause RV dysfunction. And then sepsis with all the tumor necrosis factors, the interleukins and prostaglandins and all that endothelial dysfunction, capillary leak, hypoxic pulmonary vasoconstriction, and other arrhythmias, mechanical ventilation. All these things can cause a positive TAPSE or a decreased RV functionality. We looked at this UCI. We did a study called what we call TAPSE-PAPSE, which is TAPSE in the setting of acute pulmonary symptomatic embolism. And so we basically did a little box plot here, and then in patients who had small or no PEs, their TAPSE values were a lot larger than patients who had large PEs. Their TAPSE values were a lot smaller. Cool. All right, next case, 38-year-old female. This is a bus driver. I will never forget this patient. She was driving her bus. She's very, very, very obese. She smokes 5 cigarettes a day. She takes oral contraceptives. She's kind of a bad historian, but boy, was she sick. She was tachycardic, hypotensive, tachypneic, and I was really worried about her. I mean, she's a smoker, pretty sedentary life as a bus driver, pretty short of breath, and she's on oral contraceptives, all of which makes me think about she could be having a pulmonary embolism. So I'm explaining to the dad, like, okay, so for PEs, we got to get her in the CT scanner. She's kind of large. I'm worried about getting her in there. I'm not sure where she's going to fit. We're talking to CT techs, all this stuff. And the dad's at the bedside. The patient grabs my arm. She says, "Doctor, it feels like I'm going to die. Am I going to die? Don't let me die." And, sometimes patients say that, it's kind of like scary. But this 38-year-old female really grabbed my arm. And I was like looking at her going, God, she looks terrible. She actually could die right now. And so I'm explaining to the dad that, and to the patient just about the risk factors when you give TPA, because if she codes on me right now, this is indeed a PE, and we're thinking about TPA. So I'm telling the nurse to go get the TPA box, the clot box. So she's bringing that over, opening it up, and I'm explaining all the risk factors to the dad. And I say, one thing I want to do is I want to look at your heart just to confirm, that there's right ventricular strain. So I look at the heart and I see this. And this is a subcostal view of the heart, and the left ventricle's down here, the right ventricle's up here, the right atrium is right here. And all of this here is fluid that's around her heart. And her heart's actually dancing back and forth, or there's a trampoline effect. This is not a pulmonary embolism, my friends. This is pericardial tamponade. And I had to, make sure that the nurse didn't give the TPA already, because that would have been a terrible situation for this patient. So I told the dad, I say, hey, listen, actually this is not a blood clot. Now that I'm looking at this with ultrasound, I was wrong. This is actually a little embarrassed. This is actually pericardial tamponade, and it's actually pretty easy to fix. We just have to take a needle, put it through her chest wall, and draw the fluid out. And at that point, he wasn't really having a lot of confidence in me, but I convinced him to do that and the patient, and we went ahead and drew back like 250 cc's of straw-colored fluid. And in the light of day, when you look at her, after she got admitted to the hospital for this, she definitely had a malar rash on her face. This was her kind of presentation of lupus, no history of lupus, but kind of a late presentation of it, I guess. And but yeah, we got that straw-colored fluid out of there. She did well. This is another cool case here. This is Avery and Chandler. They were my patients, and that's their mom. And basically, I got this sign out that Chandler was having shortness of breath and dyspnea on exertion, and had an episode of near syncope while playing soccer. So the sign I got was chest X-ray, just make sure everything's cool, and then you could discharge her. So I went in the room to talk to the family. Chest X-ray, of course, was not useful. I went in the room to talk to them. I brought the ultrasound machine there. I was gonna use the machine to look at the IVC and then give her a lecture on being dehydrated. I don't know why that was going through my head. I'm just going to show her she's got a flat IVC, and then she's dehydrated. But But what happened is when I looked at her IVC, I saw this. And so this is the short axis of her IVC over here, and this is the long axis of her IVC down here. And this is what it looks like with color, and you can see there's a big filling defect here. And so what does she have? She has a blood clot in her IVC. And it was kind of working its way up from the lower extremities, and she has a DVT. And so with all the shortness of breath, I got a pulmonary CT angiogram, and she had bilateral pulmonary emboli. So just totally stumbled upon this diagnosis. Her only risk factor was she's on oral contraceptives, little procoagulation there. So we got her anticoagulated, and I followed her up. They wanted to get repeat CT scans every month on her, but the mom didn't want to do that with all the radiation. So I agreed to follow her up in my office, actually. I don't have an office. I mean, I don't see patients in a clinic because I'm an ER doctor, but I do have an office. And so she'd come back every month, and just for fun, we would do an ultrasound, and the clot was gone and disappeared. And then her twin sister, Avery, started having the same symptoms. And so I diagnosed her with the DVT, and then she got put on anticoagulation. And they did all this protein CNS studies. They didn't know what it was. Really, the only risk factor was like oral contraceptives. So there you go. Here's another case. 70-year-old guy comes in, choking episode, local restaurant. Bystander comes along, does the Heimlich maneuver, and before the paramedics get there, paramedics bring him to me. They're rolling him by me, and the guy's sitting up now, kind of looking around. Looks great, and I said, "What's going on?" To the paramedics, they go, "Oh, this guy was choking. Someone did the Heimlich maneuver. I don't know. We just thought we'd bring him in, just get him checked out, you know." I'm like, "Okay, thanks." And then like 45 minutes later, a resident comes up to me and says, "Hey, Fox, they brought this patient in for a choking episode, but I'm talking to the guy, and he's at this restaurant, and then he actually passed out. Like the next thing he knows, they're doing the Heimlich maneuver on the ground. So I think we got to change our algorithm from choking to syncope." And this 70-year-old guy with history of hypertension, I do the physical exam on him. The only thing that hurts is where, they squeezed him during the Heimlich maneuver. And I don't know, I'm worried about AAA on this guy. So I kind of roll my eyes. I'm like, okay, AAA. You went from choking to a AAA? Come on. But, these residents, they're smart. They're onto something. And we go in there. We do this ultrasound on this guy. And sure enough, he's got this large aortic aneurysm in his abdomen. And, it's like 8, 9, 10 centimeters there. And so went ahead and, called the vascular surgeons. And even though the guy looked great, so probably what he had was what they call sentinel bleed, where you bleed from your aortic aneurysm, then you have syncope, and then you wake up and you feel good until you fully rupture your aneurysm. And we all know how these are so difficult to diagnose, especially because of all that mural thrombus. Here's another example of an aortic aneurysm with a large mural thrombus. The dampening effect that it causes prevents us from making the diagnosis. Here is another example of an aortic aneurysm with just some kind of turbulent swirling flow there with the color. You don't need the color, but it's kind of fun to see how turbulent the flow is. Here's one we had on an island off of California, critical access hospital, and this patient has a large aortic aneurysm here seen on that island. And the call I got was, "Hey, this is what I think it is, what I'm looking at, right?" And I looked at this video taken with an iPhone, and I said, "Absolutely, get that patient off your island right away. That is an aortic aneurysm. Again, syncopal episode, abdominal pain, back pain, groin pain. Think about that." Here is a 32-year-old female. She has diabetes. This diabetic female, immunocompromised female with diabetes, came in with arm cellulitis. You look at her arm, it's kind of red, and you go, "Okay, you have diabetes, you have cellulitis, probably need to admit you for IV antibiotics." No, I want to go home. But then you examine her, and she's super tender. And you go, "No, actually, I'm going to do an ultrasound to make sure, you don't have an abscess down there or something worse." And this is worse than an abscess. What is this? This is necrotizing fasciitis. Well, how do we make that diagnosis on ultrasound? Well, in this patient's unbroken skin, you should not see any evidence of air. And all of this down here is gas. So we know that it's a polymicrobial infection with gas-producing organisms, and all this white stuff, all these white dots right here are gas. And so, yeah, absolutely. Necrotizing fasciitis, ultrasound is fabulous for diagnosing that. Use the linear probe, and you look for punctate dots in air. Here's another example. All this white stuff here under unbroken skin. Hey, look, it's one thing if somebody put a needle in here and, introduced air, and that's why you see all these dots of air, but not in unbroken skin should you ever see that. That's neck fash. Okay, here's a 42-year-old developmental delayed gentleman who was unable to speak. He came in with UTI. The caretaker said he gets UTIs all the time, usually just needs some antibiotics. We'll be out of your hair, doc. And I said, well, he can't really speak to us, so yeah, I checked his urine. It's definitely infected, but hold on a minute. And I look at his kidney and with ultrasound, and he's got all this obstruction here. He's got a basically moderate amount of hydronephrosis. I said, does he have any history of kidney stones? They're like, no, doctor, just infections. Ready for our antibiotics? We want to go home now. I said, no. I'm seeing a dilated kidney here. It looks like it's obstructed. He could have a kidney stone that's infected, showering, blood and bacteria into his blood. He couldn't really talk to us. He was a little diaphoretic looking, and he's had a low-grade fever. Vital signs looked pretty good, though. So I got a CT scan. Sure enough, he had a large kidney stone that was causing a hydronephrosis that was infected. Then he ended up going for a procedure to have that kidney stone removed. So again, ultrasound in this developmentally delayed person who's unable to talk to me enhanced my ability to take care of him and lowered my threshold to pick up a life-threatening diagnosis. Here's a 56-year-old female. She came in with flashers, meaning that in her visual field she was seeing these flashing lights. And I'm doing an ultrasound here of her eye. This is her optic nerve sheath back here. And as she's looking around, I'm seeing this kind of like snake-like thing in her eye. And when I see that snake-like thing, her visual acuity was intact, but she was having flashers. So when I see that snake-like structure, I think about a retinal detachment. And then I talk to the patient. She's like, yeah, no, I can see out of that eye. It's just I'm having all these flashers and floaters in my visual field. And so to me, this is a retinal detachment, but it's still attached at the macula. The macula is lateral to the optic nerve sheath. The optic nerve sheath hangs down behind the back of the eye. That's that shadow that you see there. And the retinal detachments, they're always attached at two places. They're attached at the choroid, which is up here, and then, they're attached at the ora serrata, which is up here, and then down here posteriorly at the choroid as well. And so, again, here's the macula. It's lateral to the optic nerve sheath. And so it's always lateral, not nasal, but lateral. And so if that's where your retina is being detached, then you have what's called a MAC-on retinal detachment, which is much more of an ocular emergency than a MAC-off retinal detachment. MAC-on, here's your retina, it's still attached at that macula, and the patient has really mild symptoms like flashes and floaters. So when somebody tells me they're having flashes and floaters, sure, you could think about other non-emergent things like ocular migraines, or you could think about, like vitreous hemorrhage. But I really want you to think about retinal detachments, even in patients with intact visual acuity, because this needs to be lasered down in order to prevent it from becoming a MAC-off detachment. And so just sort of an example here, we see this retina detached over here, but where the optic nerve sheath is and just lateral to it, it's still attached. And so this is an ocular emergency. And I think about like a cobra that's sitting with its tail on the macula, but it's detached at the up towards the ora serrata. MAC-on detachment. All right, and here is the 17-year-old male, sore throat and a fever. And sore throat and a fever, I'm thinking about what? I'm thinking about probably going home from the ER. Sore throat and a fever. I just want to look in the back of the throat, make sure there's no peritonsillar abscess. And then the other thing I do on these young patients that worry about acute infectious mononucleosis is I look at their spleen. Do I send a test for mono? Usually not. It's very clinical diagnosis. But I just want to make sure that their spleen isn't something I'm worried about. And sure enough, this person has a gigantic 20 centimeters spleen. A normal spleen is more like 13 to 15 centimeters, but once it gets above 17 to 20, boy, you are telling the 17-year-old male he cannot do any sports for 3 months until the spleen goes back down again to a normal size. And I would follow up this with an outpatient ultrasound in about 3 months. Here's a 22-year-old male. He got into an altercation over an iPhone. Somebody stabbed him in the chest to steal his iPhone. And you can see here, this is his liver up here. Here's the pericardium coming along here. This is the right side of the heart. The left side of the heart is down here. He's got two things inside of his pericardium. He's got a pericardial effusion, which is the anechoic fluid, and he also has a pericardial clot from the blood starting to congeal around his heart. The pericardial effusion, that's something that we can fix with a needle, but a clot, you're going to need a thoracotomy and a window for that. So this person had very low blood pressure. They were kind of going in and out of consciousness, and we made the diagnosis of pericardial tamponade right away from the stab wound to the chest. Patient went for a thoracotomy, not in the ED because they still had a blood pressure, but in the OR, which is a way better place to do a thoracotomy. All right, so that pretty much summarized it. Thank you for your attention. We talked about ruptured topics, pneumonia, fluid resuscitation, central line placement, viral myocarditis, pulmonary embolism to tamponade, clots in the IVC, AAA, necrotizing fasciitis, and retinal attachment, among other things, like infected kidney stones and tamponade. So yeah, that's me doing an ultrasound on myself in a swimming pool in Maui during a sunset. That's my heart. There, subcostal view of my heart. Thank you very much, everybody. I miss you all. Can't wait to see you again. Take care.